All right. Got my mentor, Coach Boo, one of the best again. So, uh, Coach, like nowadays, when it comes, there's more and more like ACL, Achilles tendon injury in like whatever sport. But when you talk to like coaches or physical therapists about like the return to play process, a lot of them gonna use like you let's take ACL as an example. They're gonna use like how much force they can produce on the leg extension or leg curl to dictate that how far away is like the return to play process. But like we talked a little bit before, sometimes we need to do a little bit more like holistic approach instead of like isolating one part. So can you kind of like walk me through like your return to play process from ACL injury from phase to phase?
Yeah, I'd be happy to. Eric, first of all, I kind of agree with your philosophy of a more holistic viewpoint. Obviously, if they fail a test badly, that means something, but there are some people who are performing at high levels that don't do that well in those tests either, so it's interesting. But that being said, when I look at ACL rehab, basically I see a few phases, and I don't like to use the word phases because everything should really blend in, so to speak. But you know, I guess for this purpose of organizing our discussion, we have to discuss phases. The first thing I do is I try to get them jumping, and let me explain why. First of all, I want to introduce speed and power to the rehab as early as I possibly can. And even though the knee isn't ready to train speed and power at a high level, jumps that are remediated at a very low level at least get the process started of reacquainting that person with speed and power. The reason why the speed and power component is so important is because the thing that is critical to get back in order to re-achieve high performance is the nervous system's ability to activate muscle tissue. And you can't really get that back doing slow things or easy things. You have to do things that are fast and explosive. Now, obviously, an ACL injury is that knee is not ready for explosive things at a high level, but you have to figure out how to remediate it. And you also have to train other uninjured body parts at a high level from a speed power standpoint. The other reason why jumping is because elasticity of the tissues is important. Elasticity is a big part of performance. If it's a big part of performance, it needs to be present in the rehab in the earliest stages. So that's a reason why also tissues tend to remodel themselves more resilient, to become stronger and more resilient if they're subjected to appropriate levels of elastic stress during the reconstruction, during the remodeling process. And the jumps that I use, I try to use stiffness jumps, pogo jumps, things along those lines. I'm a firm believer that one of the reasons why we have setbacks in ACL rehabs is because we involve too much flexion and extension in the rehab. Flexion and extension are big irritants. And if we are using jumps like stiffness jumps, well, suddenly now around the knee joint, we're developing lots of tension, lots of tissue load, but we're not experiencing the flexion and extension, so we get all the strength gains without the irritation. I'm a firm believer in an ACL rehab that you compartmentalize things. You do a little bit of range of motion stuff because you have to, but when it comes to the actual strengthening, you try to strengthen using exercises that are going to produce strength but involve small ranges of motion. So in short, I just get them jumping. That's stage one. My goal is to be able to get them to do simple single leg pogo jumps, and a substantial volume of them, maybe around 70 meters or so on the injured leg or such. Now, how I go about this really depends upon how far along they are. If it's been quite a while, they might be able to get into single leg pogo jumps immediately. But on the other hand, if they're fresh out of their surgery, I might have to remediate it with double leg, or even earlier, I might have to remediate it with assistance, maybe a rubber band supporting their body weight or something along those lines, or maybe even eliminate the flight phase. But the suffice it to say, I want to get them jumping. And another reason why jumping as opposed to something else is because jumping is extremely predictable and it's very controllable from a coaching standpoint and a biomechanics standpoint. So that means when I am having these athletes jump, I am actually able to use cues and make keen observations to exactly what's going on there. Whereas if a person was running, you wouldn't be able to do that. There would be too many variables there. Once they get to the point where they can do these single leg pogos with the volume isn't everything, but a decent body of work. I make the assumption that now the leg is ready to accept stress in a single leg format. So that means now we're ready to start sprinting. So this is when I move into a second phase where I actually start to sprint them. I sprint them because, again, I want the speed and the power component to drive neural processes, rate coding, recruitment, and so forth. So this is why I don't want to jog. Jogging is very it doesn't have any speed power component. It doesn't do anything neurally. Jogging is also different for everybody, and it's practically impossible to quantify. So a sprint is what I do. The typically, first workouts are typically extremely short, and then I lengthen them as I go. What I like to do, Eric, is I like to work back and forth between resisted sprinting and unresisted sprinting as I progress distances. If I have an athlete pull a light sled, for example, it's going to cap their velocity. And it's also going to put a little bit of a limitation on the tissue load that they're going to receive. The angularity of the knee is going to be reduced because of the resistance. So what I like to do is I like to have them sprint a distance with resistance, not a heavy resistance, a very subtle resistance, and test it and see if it's safe. And if it's safe, that means in the next sprint session, I can then go ahead and have them do this in a non-resistant format. Okay, so for example, on a Monday, if I sprint this athlete 10 times 10 meters, and I'll have them do resistant. If that goes well, and it always does, well, then 3 days later on Thursday, I'll have them sprint 10 by 10 without the resistance. And then now I'll try something a little longer. I'll go 15s, so 10 by 15 with the resistance. Then 3 days later, 10 by 15 without the resistance and so forth. So over the course of time, I use the resisted format to see test readiness for the unresisted format, and I progress it out 5 and sometimes 10. If it goes well, sometimes 10 meters at a time. The reason why the runs are getting longer is because the terminal velocities are increasing as the runs get longer. So if I can achieve a higher velocity at the end of a 20 than I can at the end of a 15, for example. So higher velocities mean higher levels of tissue loading, higher levels of angular velocity at the joints and so forth. And that's how I kind of progress them over time. The excuse me, the progression goes on until they get to about 40 meters. And because if 40 meters is where most people are starting to hit maximum velocity, and there aren't any additional benefits to going beyond maximal velocity, at least as far as the max velocity point, at least as far as tissue load is concerned. Now, at this time, when I start sprinting them, I also put them into a depth jump series, a drop jump series. What I'll do is excuse me, I'll take a box which corresponds roughly to their vertical jump capability at that point, which of course is not very good. Sometimes it's as low as 8 inches or 9 inches. But in any case, what I'll do is I have them do 3 exercises. They'll fall off of the box and land. They'll fall off of the box and bounce a little, and then they'll fall off of the box and immediately go into a nice smooth squat. And they have to do all three of these exercises, 10 repetitions perfectly. And what I'm looking for is I'm looking for proper amortization patterns. I'm looking for an absence of valgus. I'm looking for equal amortization, meaning, for example, in the squat exercise, making sure that they know how to absorb in the hip, the knee, and the ankle, and know how to use all three joints to amortize forces and such. So this is how I take the jump program at this particular point. So when they show mastery, they can do 10 reps at a particular height. Um, then three more boxes next time. All right. And again, the next session, as I said, is always, 4 days later, two rest days in between, is how I do it. It's also about this time that I start to reintroduce the weight room as well. Um, Olympic lifting is bilateral, so I'll have them do light Olympic lifts. Light because of the bar speed, and the bar speed seems conducive to producing the same neural adaptations that we're trying to get with speed power training. So basically, it's around 50, 55, maybe 60% with high bar speeds, nothing heavy at this particular point. Not because I'm against heavy, but because the speed is what we really need. What we're trying to do is reestablish rate coding capabilities, and the velocity seems more conducive to that than heavy lifting would actually be at that point, although heavy lifting is important. Not long after that, I'll start to do some bilateral squat jumps and things of that nature. I stay away from the slower forms of strength, like squats, for example, of different types. The reason why is because these exercises are very fatiguing on proprioceptors, particularly muscle spindles. And at a time when I'm really trying to get nerve and muscle to play well together and reconnect, so to speak, the last thing I want to do at that time is introduce some proprioceptive dysfunction or proprioceptive challenges. So I try to stay away from the heavier, slower kinds of strength, and I only use the faster, more ballistic forms of strength. You can get just as much tissue load, and you get just as much, get better neural activation. And if you have neural activation and tissue load, you're getting strength, whether it's looks like a strength exercise or not. Once they kind of get to this through this, where they're starting to achieve maximal velocity in the sprint program, and the drop jump box heights are starting to become significant, um, they're typically ready to go. But the third stage is inhibition removal. Anytime you have a significant injury, anytime that you have what's the word I'm looking for here, something very damaging or potentially a surgery, uh, you're going to have neural inhibitions. And these neural inhibitions have to be removed. If you don't, this is the reason why they go back and they injure something else. So, what you have to do at this point is they have to train at a really high intensity. So, this is when I will have them do maximal velocity sprint work. This is when I'll continue that drop jump series into significantly high boxes. This is when I also start to introduce heavier Olympic lifting every other session as well. And the whole purpose here is simply training with intensity, because intensity is the only thing that's really going to break through these inhibitions. And it normally takes 3 or 4 sessions of these high intensity training in order to break through those inhibitions. And then, kind of after that, you're pretty much good to go. The way I work the whole rehab throughout is I work it in 3 day cycles. The first day is always speed and power training for uninjured body parts and modified speed power at the injury site. The second day of the 3 day cycle is always circuit training, body weight circuits, medicine ball, things of that nature. And the reason why is I'm trying to drive lactate. If I drive lactate, I drive growth hormone responses, and basically that makes them heal faster. Because of an improved souped-up endocrine system, then tissues are going to remodel at a faster rate. Some people are fast healers, and you can make someone a fast healer if you know how to manipulate the endocrine side of it. And then the third day of the 3 day cycle is a rest day, or a day where you just might go to the training room, use modalities or something along those lines. I never train more often than that. People find it odd that I only train the knee every third day. But I find that I'm able to achieve higher levels of intensity if I give them the extra rest. And I think that sometimes we try to do it a little too frequently. And as a result of that, we don't achieve the levels of intensity that they're capable of handling. And because we don't provide the rest, that's when we start to get irritation and setbacks and things of that nature. So I'd rather hit them hard on a Monday and then not hit them again till Thursday, as opposed to grinding on it, so to speak. So that's kind of it in a nutshell what I do. I don't have phases per se because what I do is I kind of observe every single day and I'm always trying to take tiny steps forward. I'm always trying to do things that are just a tiny bit more intense than the stuff that they did a little bit earlier or a few minutes ago or whatever. I call it a micro testing kind of philosophy where I don't believe in like sticking in a particular phase for a certain period of time. If you stick in a phase for a certain period of time and the athlete really has mastered that phase, then you end up wasting time. And wasting time means that you're doing busy work, and busy work increases injury risk without any potential for improvement. So that's basically the philosophical approach I use, and it's kind of how I organize it and the phases and such.
Nice, nice. So, um, usually if an athlete got an ACL injury, they probably gonna take like a year or even longer to like return to like performance. So with your protocol, like how fast would you like think you can help them get back to like perform?
Yeah, 5 months is kind of my standard, but I want to make it a point to say that like it's not a race. Ultimately people progress at different rates and so forth. But I feel that that standard you mentioned is probably a little excessive. I think that what happens in these situations is that the athlete tears the ACL and rehabilitator, therapist, every doctor, everybody is concerned about the integrity at the injury site. And what happens in the meantime is all of the other things that made them a good athlete, nervous system qualities, endocrine qualities, all of those things erode completely. So when this athlete finally shows integrity at the injury site, we don't have to worry about the injury anymore. So much of that stuff has fallen off that it's a long road back. But I'm convinced that you can continue to work on rate coding, you can continue to work on endocrine responses and such in the earliest stages of the rehab. So instead of doing tissue integrity and then look at the athletic side, you can actually do both at the same time. And I think that's why it goes a little faster. Again, emphasizing it's not about being as fast as you can. That's not the hallmark of a great rehab is being done a week earlier than someone else, but I do think that those numbers are very, very possible. Those timeframes are very possible in most of your normal situations. Yeah, and I've done it myself.
Cool. So, so after ACL surgery, how fast would you let them do assisted jump?
Assisted jumps
Yeah,
almost
assist.
immediately, like a couple of weeks later. Now, keep in mind now, it just so that your listeners understand, not only is it assisted, but I might even eliminate the flight phase. If you can picture somebody kind of bouncing up and down, look like they're jumping, but they're actually not leaving the ground because they're not ready to do that yet. It's almost like a vertical vibration, so to speak, where they're holding on to like I'll bring it down as to as low a level as I possibly can. So if I tell people that they're jumping a couple of weeks after surgery, like people kind of get excited and freak out. But when you see what it actually looks like, it's really not much. But the bottom line is though we're working at it. It's the first step in a progression. Yeah.
Cool. And so after the athlete can hit single leg pogo jump for like 70 meters, they're gonna do sprinting.
Hmm. That's correct. Yeah, philosophically, I just feel that if you can accept impact in a single leg format in those jumps, then you're ready to sprint at that point. Right. What's interesting about when you start sprinting them is that the sprinting is really not a challenge. It's really pretty easy. The hard thing is not the sprint, it's the deceleration, like actually slowing down from the sprint. So an athlete being ready to sprint 10 meters is ridiculously easy, and I've never had anybody have a problem with that. But slowing down afterwards can be a little scary. So that's why sometimes I'll use the resistance because the resistance helps them with the deceleration. That's why sometimes if I tell them to sprint 10, they're required to decelerate over 20, like a long decel zone. And I'm always looking at body language too, during the deceleration phase to make sure that they're comfortable there. It could very well be that they're ready to sprint a distance, but they're not ready to decelerate from that distance.
Cool, cool. So, that's for the ACL return to play. Would you say like your Achilles tendon return to play process will be different, or it's kind of the same?
I think it's different, to be honest with you. Uh, First of all, it's important to understand why it happened in the first place, because a lot of times there are, immobilities in the foot or whatever the case may be, possibly training baggage or whatever. But that's the first step in a rehab is to figure out why it happened in the first place. A lot of times we do a rehab, and after we do the rehab, person goes back and they re-injure themselves, and we assume that we sent them back too fast, or we assume that the rehab wasn't done properly. Well, it could be that everything was done properly and it wasn't too early, but we didn't identify why it happened in the first place, and the injury cause was never addressed. But I think it's different. I think Achilles injury is different than a ACL injury because tendons are unique tissues. Tendons really only respond to load. Tendons don't get better by themselves. If you have an ACL, if you rehab it, great. But if you don't rehab it, it'll eventually be okay. Tendons, not so much. Like you really have to load tendons in order to get them to do anything, in order to get them ready. So with most of your minor Achilles injuries or minor Achilles discomforts and whatever, I like to do jump-based rehab with them. The Achilles tendon, it's built to take stretches. It's built to take violent stretches. That's kind of what it likes to do. So a lot of times what I'll do is I'll just take an athlete who's having Achilles discomfort or whatever the case may be. And if I know it's not a significant or a very serious issue, I'll bring them to an uphill surface and I'll have them just hop uphill. By hopping uphill, the heel is not supported, so the Achilles gets to take that long stretch that it kind of likes. In many cases, with Achilles rehab, we tend to nuke that area with concentric exercise, band exercises, toe raises, and things of that nature. And a lot of time, those exercises just tighten things up and kind of make it worse. In my lifetime, I've inherited a lot of Achilles tendon rehabs that were kind of stuck and weren't getting better. And in just about every situation, I just kind of discontinued everything that they were doing. And I just started doing jump based rehab. And as a result of that, everything broke free and the tendons was asked to do what they like to do and things got better. Now, that being said, to be perfectly clear to your listeners, this is in situations where there's no real imminent danger of rupture. If there's imminent danger of rupture, we still have to load the tendon. But I like to use isometrics in those situations. So I'll, use some type of isometric exercise that'll anatomically reach that area. So in short, if the imaging tells me there's danger of rupture, then isometrics is typically the way to go. But I don't like using isometrics if I don't have to.
Hmm. So before we dive into the Achilles tendon rupture return to play, um, kind of want to ask your thoughts on like why is there more and more Achilles tendon tear like recently?
I don't know that anyone knows, to be honest with you. I do think that a lot of it sadly is related to PED usage. And I'm not pointing at any one particular case or anything, but that's an area that is particularly subject. If you overuse PEDs or certain anti-inflammatories or whatever, some of these powerful cocktails make that area a little brittle. And so some of it is PED related. Also, a lot of it's related to foot immobilities. I've Most of the people I know that have had Achilles discomfort problems, whatever the case may be, a lot of times the cuboid bone is stuck, or there's something going on in the foot where bones are not gliding against each other the way they should, and the foot's kind of lost its shock absorbing ability, and it's lost its ability to transmit force through itself. So that's part of it as well. And the third part of it is kind of what I said earlier. I think that sometimes we we identify an injury and we go to work strengthening that injury or that area, I should say, to prevent injury. And if the training isn't correct, it might make things worse. So I think what happens is people get nervous about Achilles tendon injuries. So next thing we know, we're nuking these athletes with calf raises and band exercises, and we get that area tight. And now that we've gotten it tight, we've actually possibly made things potentially worse. This is a reason why in my program I really don't train the Achilles tendon per se in isolation. We sprint and do plyos and all that kind of stuff, and that supplies a lot of very specific, sport specific load to that area. But to say that in the weight room I do isolated Achilles work or whatever, I really don't. The few good coaches I know that do that, it's practically all eccentric or something along those lines. So I think you have to be careful. Fooling around with baseball players, I learned a long time ago that certain body parts or certain areas of the body just don't respond well to concentric training. Um, like baseball players, for example, baseball players, a lot of times they'll do the dumbbell wrist curls or they'll do the rice bucket in the clubhouse or whatever because they want those big old Popeye forearms. And what happens is that forearm gets tight, and next thing you know, they got an elbow issue or something like that. My point is that the forearm is an area of the body that's sinewy. It doesn't have a lot of muscle mass. It doesn't respond well to traditional concept strength training compared to like the forearm to the hip. The hip is heavily muscle, the forearm is slightly muscle. And I think the lower leg is kind of the same thing, fits into the same category there in that regard. If you overdo traditional concentric training, I think it tends to tighten up, and that might be part of it. So, so in short, uh, our friend Adam Pedway has done a fantastic job of isolating the mechanics of Achilles injuries, and I know you're familiar with that work, and a lot of your listeners are. But as far as why this person suffers it and why not, I think those are some of the potential reasons.
Yeah, because uh it's interesting that I was in a car with Adam and Garrett from Tennessee at the same time. Then they're discussing about all these like injury mechanisms, but at the same time, like different player exposed to these positions from time to time, and they're okay. So it's like really, really nobody knows what's going on and why is it happening.
So we know the mechanics that produce Achilles ruptures, but why you and not me, or why me and not you? That question is still a little bit vague, and I'm just giving you my ideas and my take on it.
Nice, nice. So, uh, now we're gonna probably dive deep into like the Achilles tendon rupture return to play process. Can you just like share your process on Achilles tendon return to play?
Oh, it's simple as heck. Like, every 3 or 4 days, I I start to subject them to isometric loading in that way. Just bring them into a weight room, and it might start off with body weight and then putting weight on their shoulders, no movement, just basically isometric holds and that type of thing. And then when we start to get some traction or whatever, then we can get a little heavier. And then when we feel like we're finally ready, then we progress into a jump-based program, not totally unlike the progression that I used in the ACL discussion we had earlier.
So, how far away, like, or like how many sessions, or like, is there a benchmark that when you hit what kind of benchmark, then you can start like jumping them?
Well, I'm testing on a fairly regular basis. Like as soon as remember, everything I do isn't based upon uh, a spot on the calendar, so to speak. But when we're starting to do isometrics that are significantly heavy, well, that's when I start to try to micro test as far as the jump work is concerned. Okay, so it might be now, okay, we're isometric holes are looking pretty good here and we got a substantial weight. Let's try some assisted jumping, in a squat rack or whatever. And try it. And if it fails, well, okay, then we just continue doing what we're doing. So everything is guided by testing. Everything is guided by observations more so than a arbitrary date on the calendar.
So how heavy would you go on those like isometric calf?
Oh, I've had as much as like 300 pounds on a person's back at a time. But again, they're not moving. They're only holding. Yeah. But of course, then it gets to a point where you have to progress to that. Is what I'm trying to say. It's not unusual to start at body weight. With
Hmm.
with the ball of your foot on a 2x4 and the heels hanging off.
So is it like a standing calf raise position or is it
Kind of
like
like, yeah. Mhm.
okay. So for
And we
Achilles
try to
tendon,
hit it at different positions.
oh,
With a plantar flex position and also a dorsiflex position.
so usually for you, like just out of curiosity, how like usually how much time did it take for you to help an athlete return to performance from Achilles tendon tear?
It's a while, like 8 months or so, and even then they may not. Achilles tendon rupture is a severe injury, and you can be a rehab whiz, and that person might never be the same athlete, unfortunately. But 8 months is kind of like a somewhat optimistic time frame.
Yeah, like usually it's probably gonna take like over a year.
Yeah, could well be.
So with with these these type of injury, like like you mentioned, like nowadays people kind of like let PT do their work and then strength coach followed it. It's not like a holistic approach. And with their approach, it's kind of like uh everybody's working at the same time. Am I correct?
Well, I think every situation is different. The model you're describing exists. There are models where physical therapists know how to take people into higher levels of stress and higher levels of intensity in the rehab process. And there are models where once you get to a certain point where more specificity and intensity is needed, you got to switch protocols. So I'm not prepared to really make a general statement about how these rehabs always take place, and of course, there are factors that come into play that have nothing to do with the rehab, like insurance factors and licensing factors and all of these types of things as well.
Cool. So another question is, I think it's last year the NBA just published a paper about like, um, for all those basketball players, their metatarsal joint is stuck at a age of 21 years old. So in your mind, like, or with your experience, how would you handle that?
Repeat that. What did they see at 21 years old?
So the basically their metatarsal joint and subtalar joint are stuck.
Oh, well, there you go. The chiropractic adjustment and soft tissue work and targeted interventions in that particular area. Yeah. And the thing is that what I find happens with young people is they're kind of think they're bulletproof a lot. So they have this issue, and it's your issue, and it's going to be your issue for your entire career. So they get it treated, they get it fixed, they get it going, everything's good, and they assume it's never going to happen again when actually it's always going to be lurking beneath the surface. I just try to make athletes understand that this is going to be your thing for your lifetime. And as long as you want to compete at a high level, it's something you have to stay on top of and keep, you know, continue to address.
Yeah, okay. So another question I want to ask is nowadays, no matter like ACL or Achilles tendon, return to play, a lot of the coaches will use force plate testing. So, uh, like, what are your thoughts on like using force plate to be as a benchmark for like these return to play process?
Well, I can see how in jump-based training and things of that nature, it would be easy to set up progressions of intensity if you actually have the data and such. And the other nice thing about the force plate is if you have pre-injury benchmarks, that tells you a lot about real preparedness as far as return to play and such as well. So just opens up other avenues. I personally haven't done. I haven't done many I've only done a couple of ACL ruptures in my lifetime where I've done a basket full of ACLs, but it's a useful tool. Yeah.
Nice, nice. So, uh, all right. So, what if today, like the athlete we're talking about is not injured? Can you kind of share like your battery test of an athlete like training? Like he's not injured, but just a battery test you'll do.
Oh, well, I have a lot of them, but I'll just kind of share with you what I do on a regular basis. Doesn't really matter who you are. There's 6 tests outside of the weight room that I like to use. Uh, 2 of those tests are done simultaneously. It's a 40-meter sprint with a split time at 30, and of course, you have a fly 10 time at the end. This tells me something about their accelerative power. And even though it's not a true max velocity test, it's close enough to kind of tell me what I need to know. So this would be like the chief run test that I tend to use in that respect. I use 2 jump tests. I like standing long jump and standing triple jump. Standing long jump is more of a power test. Standing triple jump is more of an elasticity test. If you're wondering why 2 jump tests, don't consider those tests to measure the same thing. One is more of an elasticity test. When you're looking at overtraining issues, you'll start to see drops in elasticity before you see drops in power output. So that's why I like doing both. If I see an athlete who's standing triple jump is dropped and their standing long jump is still okay, that tells me they've lost elasticity, their power levels are still okay, and that tells me something about the level of overtraining that they're experiencing. I do throw tests as well, an overhead back shot throw or med ball throw, and a between the leg forward shot or med ball throw for distance. These are tests of explosive power, and they tell you something about explosive power beyond your body weight resistance, so to speak, like a standing long jump or a vertical jump would. The explosive power, if you're wondering why 2 tests and not one, it tells you something about coordination. You know, both of these tests kind of measure the same thing. So if you are doing 2 tests and they're good at one and bad at the other, it tells you something about coordination. It tells you something about skill levels and such. So those are the tests. So those are the 6 that I kind of go to. As far as other key tests, I constantly monitor athletes' uh, power clean maximums, and I monitor their subparallel squat maximums. And that's basically it. There's a few other tests that I'll do depending on a sport, depending upon an event, depending upon a time of year, but those are the ones that are kind of like always in play at any time of the year.
Nice, nice, nice. So, uh, another injury I want to talk about today is like groin injury, and I know we kind of already talked about this before, but still, like, why do you think there's like more groin injury, like more and more right now?
Well, I go back to the root of it is that I feel that training of that region in many sport cultures has become somewhat gimmicky, so to speak. Okay. A lot of times, if we look at groin injuries and we're looking at adductors and abductors, Gray's Anatomy calls this muscle an adductor and this muscle an abductor. Okay. So sometimes we kind of feel like, well, if I'm in a weight room, I got to make it abductor, I have to make it adduct. And that's not really what they do from a functional standpoint. These are muscles that when you're sprinting or running or whatever, or even changing direction, what they're really doing is they're more stabilizing. If you're in single support adductors are kind of like that. And heck, the adductor magnus doesn't even really act like an adductor. It's more of a hip extensor than anything else, to be honest with you. But that being said, I think that some training cultures, we've gotten too far into the Copenhagen benches and those types of things. And instead of understanding that even when you have groin issues, it's still pretty much a sagittal plane type of rehab that you really need to do in these areas. Like I've seen a couple of programs that have had some groin issues, and then they went kind of whole hog on the Copenhagen bench stuff and all of that type of stuff, and it blew up into massive numbers of sports hernias because of this. So So again, I think it's just train muscles to do what they normally do and don't get overly wild or crazy with what you ask them to do. These some of these hyperplanking and super planking exercises or these exercises where you have to pick the med ball up between your feet and do these things or whatever. Maybe in tiny doses, those are fine, but like in when you start really building a program around those types of things, you're really straying very far from functional training and functional movement. And it's just not what we're designed to do.
Nice, nice, nice. All right. Last thing
And by the
before.
way, one other thing, that area is particularly tricky as well. It's tricky. It's subject to movements of the sacrum, pelvic oscillations, and all of those types of things, and rotation of the femur. All of these, it's a really tricky area as far as rotation and such is concerned too, which makes it a little more tricky, a little probably a
Mm,
little more complicated than downstream a little bit.
mm. Oh, so this actually mm, reminds me that I was actually talking to Dan Paff the other day, and he mentioned that there's possibility that a lot of the Achilles tendon discomfort come from like they don't have good mobility around this lumbopelvic area, especially the SI joint.
That's very possible. And he's just pointing out something that I believe very strongly in is that very often a particular injury, the actual root of that injury is somewhere else in that kinetic chain. I'm of the opinion that most of these things come from the ground up. The collisions in sport, in non-contact sport, are between the feet and the ground. So in most situations, they're ground up, but they can be spinal outward or pelvic down or whatever. Ultimately, that's why a book like Myers Anatomy Trains or whatever is such a valuable resource because it gives us the roadmap to kind of trace these types of dysfunction. Yeah.
Nice. All right. So this leads me to another question, probably a stupid one. Since like everything you do is assessment, and we talk about like the injury probably come from like let's say uh probably a lot of ACL come from like they don't know how to decelerate or like Dan Path mentioned some of the Achilles tendon tear probably come from lack of movement, lack of mobility of somewhere else. Do you do like some sort of like static mobility testing or static movement testing at all?
A little bit for the feet, but most of the testing I do is more dynamic movement. I want to watch people when they're running and jumping and look for symmetry of pelvic movement, look for a balance as far as internal, external rotations and so forth, look for symmetry of rotations from right side to left and so forth. There's lots of people who show okay on a table and then won't move well. So I'm not saying that that's not a good place to start, but I really think that what the better people are doing is they're just a little bit better at looking at people when they actually move. And that kind of tells you where to go on the table as opposed to figuring out on the table where you need to go, I guess. Saves a lot of time too.
All right. Last question. Last question. So, I feel like nowadays there are more and more like medical side of like people taking over like strength coaches, ATC. There's like PT taking over like strength coaches whatsoever. So, what I want to ask is like, can you give like the young strength coaches some recommendation or advice for them to like be better at like these jobs or like since PT are taking over like everything?
Yeah, I advise young strength coaches and professionals, period. Remember, be a generalist. Okay, be a generalist. Ultimately, as a strength coach, you're good at one particular thing. But as a strength coach, you should be able to do a return to play plan. You should be able to teach certain skills and so forth. Um, I personally, and again, not to sound conceited or whatever, but one of the reasons why I'm on your podcast is because I can move fluidly from a strength and conditioning environment to a return to play environment to a sports skill environment, and I can operate at a high level in all three of those areas. And I think that sometimes we tend to get too tunnel vision and we value depth of knowledge and we undervalue breadth of knowledge. You know, when we look at vacuums are always going to disappear. So when there's a sports organization and there's an absence of expertise in a particular area, somebody's going to fill it. Like, you know, and it's typically the person with the most confidence that fills it, not necessarily the person with the most skill in those scenarios. So in good sports training organizations, there's overlap, meaning that instead of the strength coaching is doing this and the physical therapists doing this, they all overlap to some extent. Now, overlapping means you're going to have headbutting and conflict at times, but it's healthy conflict. It's healthy headbutting. You know, it's far better than the silo approach where everybody has their own little wheelhouse and nobody's communicating. So that's my advice is to ultimately understand that you have to be a generalist and that developing your problem solving skills is probably the single most important thing. You know, like athletes are going to go where they get their answers, they're going to go where their problems become solved. And it really doesn't matter what your name is or what your alphabets are behind your name in those situations. They're going to go where they get the help that they ultimately need. You know, I've worked in college situations where an athletic trainer got kind of upset with me because athletes were coming to me for return to play and such. You know, and I'm kind of saying, look, that's not really a me problem. That's kind of a you problem. You know, it doesn't really matter what's on the door beside your office. It's ultimately, if they're coming to me, you have to become better with your problem solving skills. And that's the other thing that I would tell them is be a generalist and understand that your problems are your most valuable thing because they're the things that really drive your skill improvements.
Cool, cool. Nice. This is awesome. I love it. So, before I let you go, for those who are interested in what we're talking about today, where can they find uh your education? And is there like a future education you're gonna host?
Um, my website is sacspeed, S-A-C, speed.com. I have a lot of materials there, including my speaking schedule. I have a lot of materials at Track as well. They kind of sell some of the materials I produce over time. And just as I said, I've got a busy speaking schedule. I'm not going to get into all of it here, but you can find it on my website.
Nice.